Hello, good evening.
Hello, David. Good evening. How are you?
Good, how are you doing?
I'm good. How was your weekend?
All is well, how is yours?
It's good. How is everyone else here?
Yeah, we are also doing good, Joseph.
Karibun sana. Yeah, so it's another Sunday.
Thank you, sir.
As usual, we are excited to have another case. And today, David will be discussing. David, I think it's about time.
Yes, it's time. Let's start.
So I have a case today, and it's not only about diagnosis, but I'll put yourself in my shoes when I was seeing this patient in my ward, and we'll discuss stuff on diagnosis and management. So it will be diagnostic reasoning and management reasoning. And so that we go with time, I think we should present the chief complaint and the HPI all together. So this was an 80-year-old male who presented to the hospital with shortness of breath and fever, and the his son reports that when they were preparing to give him a bath in the morning, he seemed to be generally weak compared to his baseline. Later in the day, he developed fever, profuse sweating, and they started having difficulty with breathing. They rushed him to our emergency, and he had. They report that he had a minimal cough. Let me admit some people. Yeah. So he had a minimal cough that had started 2 days ago, which was associated with runny nose. So other symptoms included loss of appetite and one episode of vomiting. But they denied chest pain, orthopnea, paroxysmal nocturnal dyspnea, abdominal pain, diarrhea, constipation, headache, painful urination or difficult urination, skin rash, focal neurological weakness. And that's our HPI.
Okay, so I believe this is not a completely new complaint. We've talked about complaints like this one in the past. So can I see the chief complaint? So this is an 80 years old male with shortness of breath and fever. So just to recap or to speak a little bit about things I believe we've said many times. Difficulty in breathing is a broad complaint, and when we think about difficulty in breathing, of course, the commonest systems that are involved are the respiratory system and the cardiovascular system. So uh, yes, so I think a conservative estimate is when you are dealing with difficulty in breathing, 90% of the times, the affected organ system is probably the cardiovascular system or the respiratory system. So the first approach would be to approach it in terms of organ systems, and that will be the respiratory system or the cardiovascular system. It can be neurological in origin. It can be musculoskeletal, or let me just say neuromuscular in origin. It can be endocrine, and it can also be psychogenic. But then when you combine these two things, again, just very quickly, when we are talking of fever, many times we talk about the IMED mnemonic, that is infection, malignancy, autoimmune disease, drugs, as well as uh, endocrine causes of fever. So for this particular patient, what I'll try and do is to Venn diagram these two complaints. So if you have two circles, one representing shortness of breath, another one representing fever, I find that point of intersection between these two complaints, and those are the differentials that I'll prioritize. Because we have already had the short HPI, so shortness of breath and fever, of course, one of the things that I'll prioritize. I mean, the first thing that I'll prioritize is an infection involving the respiratory system. So, going deeper into this HPI, we see that, of course, this is an old patient, and the patient seems maybe not very much independent because they were preparing to give him a bath. So I believe he has lost some degree of independence, and therefore he needs help with self-care. And then he seemed to be weak, and then he developed fever, profuse sweating, and started having difficult with the breathing. And that's when they rushed the patient to the ER. Now there is a history of productive cough, and it was associated with a runny nose. And other symptoms are loss of appetite, an episode of vomiting. So before you go into the last bullet, you have fever and then difficulty in breathing, but you also have a history of a productive cough as well as a runny nose. So basically, you are talking about something in the respiratory system, most likely something in the respiratory system. And with the runny nose, I normally tend to think about an upper respiratory tract infection. So you are talking of things like a flu, uh, or if it's not a flu, any other thing that you can think about that presents with an upper respiratory tract infection. So a rhinovirus infection, influenza virus infection, or anything of that sort, and many other viruses, commonly viral infections that present with or that cause an upper respiratory tract infection. But then an upper respiratory tract infection by itself does not cause will not cause difficulty in breathing. Of course, there are some viruses like respiratory syncytial virus, which I believe can cause both. You have an upper respiratory tract infection, you have involvement of the airways leading to bronchitis or bronchiolitis, leading to difficulty in breathing. But commonly, many viral infections will just end up with an upper respiratory tract infection and not involve the lower respiratory tract. But then with someone who had an upper respiratory tract infection, of course, they can have a bacterial superinfection, leading to a lower respiratory tract infection, especially patients of this demographic, an elderly patient, and therefore we tend to think of them as having relative immunosuppression just because of the age. But then we do not know very much about how ambulant this patient is, because if the patient is not very ambulant, then of course that's another risk factor for, because of the stasis, that's another risk factor even for lower respiratory tract infections. Yes, so that could be a possibility here. Now, going to the last bullet now, we do not see chest pain, orthopnea, PND. So I would say these partly are trying to rule out some cardiac pathology, including heart failure, and then no abdominal pain, diarrhea, constipation. Because this patient is having a fever, it's important to make an effort and try to determine which could be the focus of infection, if at all we are considering an infection. So the absence of abdominal pain, diarrhea, constipation. Of course, the patient had an episode of vomiting, and vomiting can come with anything. Uh, so yes, partly. So we are trying to look for different foci of infection, and then no headache. So headache, uh, if the infection is involving the neurological system. So for example, someone is having meningitis, they can present with neck pain, headache, uh, and then no pain for difficult urination, the urinary tract, a common focus or port of entry of infection, especially in elderly patients. So that one also is not present. And then there is no rash. So again, the integumentary system, skin and soft tissue, those are another important port of entry for infections. Yes, so up to this point, I am prioritizing an infection of the respiratory system, which probably started as an upper respiratory tract infection, which could be viral. And of course, up to this point, maybe it's something viral, but I mean, we cannot completely throw out the possibility that this is a bacterial infection. And of course, we should entertain the possibility of both typical as well as atypical organisms because of his age. Now, based on the acuity of symptoms, I think I will not go far to think about fungal infections at this point, but anything is possible. Now, apart from infections which are prioritized, other things, of course, that can cause difficulty in breathing and fever. Yes, there are other possibilities. So autoimmune diseases can do that, but then we do not see anything that points us in that direction. And of course, this is a male patient. So many times we tend to think that autoimmune diseases are more common in females than males, which is true. But then that doesn't mean that men are 100% exempted. And then malignancies, of course, the time course is very short for me to think about malignancies at this point, but I cannot completely throw them out. Of course, drug reactions, we discussed the case of DRESS here at some point. So we do not have a history of any new medications that the patient has used, but yes, DRESS can present with fever and it can present with difficulty in breathing because of the systemic symptoms that we are talking about. So I'm talking about drug reactions and then uh, an endocrinopathy. So an endocrinopathy that can present with difficulty in breathing and fever. Yes, if someone is having a thyroid storm, they can present this way. But I've just mentioned them for the sake of mentioning them. I'm prioritizing an infection, but some of the other broad differentials I've discussed about, I do not completely throw them out. And then there are other things that there are some other things that maybe we do not prioritize very much here, but we should think about them. For example, this is an 8 years old male. I've already expressed some concern about his level of independence. I'm not sure how much ambulant he is. And then he presented with difficulty in breathing, uh, which is of a short duration, and then associated with the fever. So going forward, I think I should also entertain other things like a pulmonary embolus. So I think I should end there and hear other components of the history of physical exam and see how what else comes in.
Yeah, that's pretty much impressive. And so let's proceed. Review of the system. This guy has altered mentation, but the altered mentation is his baseline. He had a injury back then, as we'll see later. Past medical history. Okay, past medical history. He has hypertension. He had a subdural hematoma 4 years ago because of a fall, and the mentation was altered since then. And he had a hip replacement surgery 1 year ago. Family social history: he has never smoked, doesn't drink, he's widowed, he has that children who are in good health. His medications include Termistan H and amlodipine for blood pressure, and that's it.
Okay, so let's go back to the review of systems, and your voice was breaking at that point. Maybe if you can repeat what you are saying.
Uh-huh. So the review of our system is just altered mentation, and this is his baseline. He had a head injury 4 years ago, and since then has been having altered mentation. So it's not something new.
Okay, so that is not a new
Yeah.
that is not a new symptom. So I think I will not spend very much. I'll not spend a lot of time here. Uh, a major interest here would be if they noted any changes, any worsening of the altered mentation. But otherwise, since you've reported that this is present from baseline, so I'll not spend much time here. Can I see the past medical history? Okay, so this is a known patient with hypertension. Hip replacement surgery 1 year ago. So, of course, when we talk, I mentioned a, 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 a a differential which was along the list, that is pulmonary embolism. Of course, uh, I think it's something that, especially when we come to physical exam, although other components of history are non-revealing, but pulmonary embolism is something, especially, let's say, if this patient is hypoxemic, it's something that we should also, even though not very likely, I think we should entertain it based on how lethal this diagnosis can be. So, but of course, when we talk of major surgeries, we talk about a number of months, 4 weeks to a few months. So, 1 year history of hip replacement, I think that is a little distance to consider this as a risk factor for pulmonary embolism. A subdural hematoma 4 years ago. I do not, of course, I think that I can't say that I know enough to completely throw it out, but uh, uh, thinking quickly on my feet, I do not see a way this is related to the current presentation. So yes, the history of hypertension, of course, the patient being a known patient with hypertension, with difficulty in breathing, of course, things like heart failure, coronary artery disease, those could be a possibility, but they do not commonly present with fevers. Although, yes, patients with the MIS can present with fever, but then there was no chest pain, although we cannot completely rely on chest pain to rule out something like an acute coronary syndrome, especially in elderly patients, because they can have an atypical presentation. Uh, mm, Next slide. Okay, nothing significant here. The next one. Okay, so these medications, I'm assuming that the patient has been on these medications for a while. When you talk about a drug reaction, um, any medication can cause a drug reaction. And Joseph taught us that rule of thumb, that when you think about dress, especially medications which start with A's, including allopurinol and others, are more commonly associated with dress. So allopurinol being one of them, and you can think about some other medications, antibiotics, those ones associated with dress. But I believe this patient has been on these medications for a long time, and we can hardly associate them with the patient's current presentation. And of course, apart from the fever, the difficulty in breathing and the cough, we do not see any other systemic symptoms. So I think at this point, I'll just have to stop thinking about the possibility of a drug reaction. So up to this point, I think I'm still prioritizing an infection, although for some reason, I think I'll have to make sure that I rule out pulmonary embolism in this patient.
Okay, that's good. Here is the exam. Patient was conscious. He was oriented to self, but not to time and
Okay,
place.
Joseph, you're muted.
Oh, yeah, I'm very sorry. So, exam. Patient was conscious, oriented to self, but not time and place. He was febrile. He was not pale. There was no jaundice, no lymphadenopathy, no lower limb edema. Vitals, normal blood pressure, pulse rate normal, respiratory rate elevated 30, temperature 39 degrees of centigrade, saturating 70 in room air. When put on 8 liters of oxygen through non-rebreather mask, he went up to 92%. Chest exam, he has tachypnic and he had crepitations on the left infrascapular region. Cardiovascular system, pulmonary, the abdomen, neuro, and musculoskeletal system were unremarkable.
Okay, the general exam, especially the vitals are striking in this patient. So, okay, he's conscious, oriented to self, but no time and place. He is febrile. The temperature is 39. He's not pale, not jaundiced, no lymphadenopathy, no lymphedema. So the blood pressure is normal for this patient. So the pulse rate normal, but the patient is tachypnic. He's febrile at 39, and then the saturation is low. So this patient is hypoxemic in a way. And so when you think of hypoxemia, I think my approach to hypoxemia, I think, is not yet very well developed. So I think I'll keep on mastering this. But so if someone is having a low saturation, so when we exclude things like maybe when the patient is very cold and the saturation machine is lying to you, uh, so we can think about it. The patient is so, for example, when the alveoli are filled with water, or filled with pus, or filled with blood, such that exchange of oxygen that comes in, so diffusion of oxygen is impaired because there is something filling the alveoli, and that can be water with something like pulmonary edema, pus with an infection. So of course, when you talk of pneumonia, it can be both edema or pus, and then blood. So for example, when there is diffuse alveolar hemorrhage, or when there is injury to the lungs due to trauma. So diffuse alveolar hemorrhage can come with anything, including autoimmune diseases. So in such a circumstance, you will have hypoxemia. But then another issue is the alveoli could be perfectly normal, but then you have a problem. So for example, when there is shunting of blood, when there is an obstruction somewhere due to a pulmonary embolus, so ventilation is fine, but then perfusion is impaired. You'll also have hypoxemia. So I think I haven't made much progress here. I mean, it can be anything. Although when we come to respiratory system examination, it helps me make a little bit of progress. So the hypoxemia that we see in this patient is I mean, can be due to any of the things that I talked about. That the alveoli are filled with something, and the likelihood that the alveoli are filled with something increases because we see that the patient has crepitations on the left infrascapular region. Now, things are not always 100%, but when I hear localized crepitations or crackles, whatever you call it, like this one, this is in keeping with a typical bacterial pneumonia, for example. Typical, meaning if we are dealing with something atypical, commonly, actually, it's not confined to a single lobe or to a single segment. So many times when you think about atypical pneumonias due to atypical organisms like Legionella, like Mycoplasma, or anything else that you can think about among bacteria, but also when you think of viral pneumonias like COVID, the crepitations are bilateral many times. They are not limited to a single to a single lobe. So we see that the crepitations are in a single lobe. So that means the likelihood that the alveoli are filled with something, that there is consolidation, let's say, although we do not hear other features when we do uh, when we do a detailed respiratory system examination, things like increase the tactile vocal fremiters, a dull percussion note. So those increases confidence that we are dealing with consolidation. So here we have crepitations, which of course crepitations can be due to anything. But in the context of this patient, I'll just make some assumptions and think, okay, these crepitations are probably due to consolidation, although I do not have other findings to help me say 100% that this is consolidation. And of course, we cannot completely throw out the possibility of a pulmonary embolism, although many times you would say a pulmonary embolism, maybe respiratory examination is normal, or if it's peripheral, then you can have some features of pleuritis. But again, with the hypoxemia, the age of the patient, I think still not a very likely diagnosis, but I think I'll still have to entertain pulmonary embolism, although high on the list, I'm thinking about a pneumonia. So those are my thoughts up to this point. Anything else?
So here are the labs. White count, HB, platelet, the CBC was normal. Creatinine slightly elevated, 150. ASCLT were normal. Troponin was normal. The dimer was elevated, was 10. Machine's upper limit of normal, 0.5. As moderate hyponatremia of 127. Potassium normal. Also hypercalcemia of 1.9. The serum amylase was elevated, 318. ESR was 50. MRDT negative. RBG 10.9 normal. The bleeding indices were also within normal limits. We did chest X-ray, and here it is. Hope you will read it. And then we send him for echo, which showed just a dilated left atria with mild mitral regurg, preserved LV systolic function with an EF of 60% and a grade 1 diastolic dysfunction.
Okay, so especially the slide on labs, I think this is very packed. A creatinine of 150, we do not know this patient's baseline. We do not know the patient's baseline. It is not markedly elevated. If we knew the patient's baseline, then we would be in a position to say if this patient has acute kidney injury or not. Now, because we do not know the patient's baseline, I think I will not dwell very much on that. Although, yes, when someone has an infection, for example, presenting with acute kidney injury or a slight elevation in the creatinine is something that can happen. The complete blood count is not very significant, so the D dimer is elevated. The D dimer is elevated. An elevation in D dimer itself is, I think, so I think we saw that if you attended patients with COVID during during the COVID pandemic, you know this, that, of course, even in many other conditions. So D-dimer elevation by itself is not enough to say, okay, we've confirmed the diagnosis of pulmonary embolism, because it can go high with many things. So D-dimer is basically fibrin degradation products. So many things can come with an elevated D-dimer. So hyponatremia. I think I will not spend very much time on a single electrolyte or a single cation, because we see both sodium as well as calcium are low. So I'll not spend much time on them. But of course, when someone has a hyponatremia, when someone has a low sodium, it could be that the patient, because especially hypertensive patients, sometimes because we doctors tell them that salt is not very good for the hypertension. So sometimes they decide by themselves, or some other practitioners are telling them to stop using salt altogether instead of salt restriction. So others will stop using salt completely, and then they get hyponatremia because of low intake of salt. So that would be one possibility. This patient vomited, but then I think it was one episode of vomiting. So I will not implicate the vomiting to the hyponatremia, and seeing a normal potassium, maybe an electrolyte abnormality from vomiting or diarrhea, maybe that is not very likely. And then we do not see a way this patient is losing. Okay, the patient is on antihypertensives, including a diuretic. I think you say the patient is on telmisartan H, right?
Yes.
Yeah, so yes, he could get hyponatremia from, he could get from, because the diuretics, I mean, they can cause anything, but especially, I mean, I think the effect would be more on the potassium uh, than than on the sodium. So when we think about thiazide diuretics, between loop diuretics and thiazide diuretics, they can both cause hypokalemia. So hyponatremia, I believe that is also a possibility, but with the normal sodium, maybe it's not appropriate to completely say that the hyponatremia is because of the diuretics. But another possibility is when someone has a pneumonia, or when someone has a lung mass, or anything else that you can think about that relates to the respiratory system, they can get the syndrome of inappropriate ADH secretion. So, and the syndrome of inappropriate ADH secretion can present with hyponatremia. So, and for infections, I think I just got to overhear this when I was listening to one case in the remote past. Someone had, especially for elderly patients like this, a Legionella infection in the lungs, presenting with syndrome of inappropriate ADH secretion, and they present with hyponatremia. So this hyponatremia, I think there are many things that can explain it, but in the context now, in the context of this patient, it's either is hypertension, maybe it's not taking enough salt, or another possibility, maybe the syndrome of inappropriate ADH secretion. So the calcium again is low. So when you think of low calcium, I think I will not spend much time here, because the individual electrolytes, and of course both hyponatremia, hypocalcemia, they are both complex cation abnormalities, because there are many causes. So for example, when you think of hypocalcemia, there are many things. It could be that you have a problem with the parathyroid itself, you have hypoparathyroidism, or maybe the parathyroid gland is working, but it's overwhelmed. It's overwhelmed because maybe the patient is losing too much calcium, or due to other reasons. But again, you could have vitamin D deficiency and many other things. So uh, I think I will not spend very much time with these abnormalities. So an elevation in amylase, I believe this does not amount, if I do quick math, maybe it's not exactly 3 times the upper limit of normal. So I would not make a diagnosis of acute pancreatitis in this patient. But it's clear that the patient is inflamed with an ESR, which is elevated, and therefore, again, an infection is a possibility based on the acuity of the symptoms. A malignancy, at least we haven't had any risk factors. This patient is a non-smoker, although even non-smokers can get lung malignancies, but the symptoms are very acute. So I think I'll prioritize infections. Yes, so I think that is what I make out of this slide on labs. Let's see the image. Okay, so this image here, uh, although the echo that we've already seen, so that is the thing, the echo that we've already seen is telling us that I think it was just a dilated LA. Otherwise, maybe if we say that the cardiac shadow is pushed, because what I see in the left lower lobe, in the left lower zones of these lungs, looks like the cardiac shadow. But if it's not the cardiac shadow, because we see that more of a homogeneous opacification, so that looks like yes, this is the cardiac silhouette. So it's probable that the cardiac apex is pushed to the left, because what I see, because there is something else that I see, especially in the at the center. You see that there is more of a homogeneous opacification, uh, which of course you can trace very properly. I mean, it has well demarcated margins. Uh, Now I cannot completely say that I'm sure of what I see, but this could be anything, including a mass, So it could be a mediastinal mass. And when you talk about mediastinal masses, uh, I think the T's can apply here: thymoma, uh, and then a terrible lymphoma. And there's something else, of course, the thyroid is a possibility. And then there's another T. I think Joseph will remind me later about the fourth T. So this could be a mediastinal mass. If it's not a mass, because consolidation does not look like this one. Why would you have consolidation in an area where there is no lung tissue? So I see something that extends. It's more seated on the left. Part of it can be seen in the right, but it's more at the center. So this looks like a mediastinal mass, I think. But of course, I'm not a radiologist. And Joseph, at this point, maybe you can just tell me what the radiologist said.
Yeah, so the other T was teratoma, and so we didn't have a radiologist at our hospital, but we had the same impression as you. But I would like to hear from you. So, are you getting another imaging to look at this?
Yeah, definitely. So for something like this, I think I'll need a CT chest in order to see what it is.
Do you need just a
Yes,
CT
I
just with the contrast, though a CT because you also considered PE as a DDX? Are you also, what do you think? CT chest or just CT angio?
uh, so for a mass like this one, of course, I'll also need contrast. But so if I administer contrast, I'll be able to track the vessels. And if there is any filling defect, of course, you could say this, if there is a pulmonary embolism or not. So with this mass, I think I'll need CT chest with contrast.
Sure. So
Yeah.
we had the CT chest with contrast, and before taking the patient there on the admission day, we started him on IV ceftriaxone, azithromycin, and heparin. We kept on oxygen through non-rebreather mask, and we sent him for CT chest the next day. Results came on the third day. They say no mediastinal muscle lymphadenopathy. They saw fusiform dilatation of ascending arc and descending aorta, and aortic dissection involving the arc and proximal descending aorta. So the conclusion was aortic dissection, and
This is interesting. Can I see Okay, interesting. Can I see the X-ray again?
All right.
Yes, I mean, in respect, yes, I think, again, considering a possibility that this is something coming out of the aorta, I think that was also that was warranted, because if you can, because again, I think things are getting clearer now, and because diagnosis is an iterative process. So if you trace from the top down, you see at the level of the aortic knuckle, you can see that the outline is clear and going down that way. So uh, yes, I mean, with this one, I can agree with the radiologist report after the CT that yes, this could also be something in the aorta. Now, what exactly is going on? So is this where you commit for diagnosis, or we have some other things to do?
We have some other things.
Okay, maybe let's just proceed.
Yeah. So yeah. So okay. The son of the patient told us that the aortic dissection was diagnosed 2 years ago. So they knew about it, they just didn't tell us. And then the conservative management was chosen by the cardiothoracic surgeons that saw the patient 2 years ago. So it is a chronic thing. It is not a new thing. And despite 3 days of antibiotics that we gave this patient, the condition didn't improve. He seemed not to be in short of breath in the ward, but his saturation were as low as 70 to 80s in room air. And when we put him on oxygen, he went up 90 to 94 through non-rebreather mask. So we argued among ourselves. Some of us says maybe this guy is having this saturation and it's normal. But we checked in the system. Luckily, he has attended at the hospital, I think for something like physiotherapy, yes. And the saturation at that point was 100. So we realized this was a new thing. What do you
Okay, so um, I mean, with the patient's presentation, with the patient's presentation, as I said earlier, that we are prioritizing an infection, and I think it's very appropriate to prioritize an infection. But then, so when you are treating an infection and the patient is not responding, there is a number of possibilities. You are using antibiotics, the patient is not responding. So what is going on? I mean, it could be a wrong diagnosis, or it could be you are dealing with an infection, but then it's a wrong bug. So, for example, you are treating a bacterial infection, but maybe you are dealing with a viral infection. So, a wrong bug, or you are giving maybe the medication, the dose that you are giving is not enough, or it's the wrong medication. And of course, that is partly if you are dealing with the wrong bug. So, for example, when there is resistance, uh, or another possibility. So I said wrong diagnosis, wrong bag, wrong medication, of course, wrong dose. So at this point, I think it's appropriate to step back and think what else can explain this patient's presentation. That what can explain the patient's presentation that we have missed. So we are dealing with an 8 years old male who presented with an acute history of difficulty in breathing and fever. There is a positive history of productive cough, runny nose, and of course, general body weakness, loss of appetite, and an episode of vomiting. but on further searching, no other ports of entry or foci of infection were revealed. And then this is a patient who has hypertension on medications. He had a subdural and he has altered mental status at baseline. And then it turns out that the patient has an aortic dissection that is managed conservatively. And then he presents with difficulty in breathing, fever, and more importantly, I think to note is desaturation. The patient is desaturated. So what could be going on now? Reviewing our thoughts so far, are we talking about a wrong diagnosis? So if we were talking about if we are talking about a wrong diagnosis, for example, pneumonia, I mean, yes, it could be something else, but what could it be? I think among these things, maybe if we say wrong bag, but if we say wrong bag or wrong organism, I see that you covered this patient with ceftriaxone and azithromycin. So azithromycin, uh, these macrolides, or if you use respiratory fluoroquinolones like moxifloxacin or levofloxacin, or if you use tetracyclines like doxy and tetracycline itself, they are known to cover for organisms that, for atypical organisms, including the organisms, the bacteria that I mentioned, uh, which otherwise would not respond to normal antibiotics. So that means that at least I think that the antibiotic coverage was appropriate. Of course, someone can have questions with the ceftriaxone because we know ceftriaxone has been used many times. So if you are dealing with something typical, for example, maybe the spectrum or resistance to ceftriaxone can be a concern. But then for atypical organisms, I think macrolides are still dependable. So a possibility that we are dealing with an atypical organism, I think with the antibiotic coverage, I think it's quite uh, well covered for me. So it could still be a possibility that we are dealing with a wrong bug, but I think at least based on the antibiotic coverage, that is probably not the case. Wrong diagnosis. So a patient presenting with fever and difficulty in breathing, and then of course we had the patient is desaturating, and we had crackles. So if it's not an infection, especially pneumonia, what else could this be? So of course with pulmonary embolism, I think we did so because CT was done with contrast. I'm not sure if the radiologist took time to trace the vessels and see there was no filling defect. But so otherwise, maybe something that we could think about and go back, talk to the radiologist in order to make sure that we rule out pulmonary embolism. I think that is warranted. But apart from that, uh, our patient, who of course is known to be presenting, is known to have aortic dissection, and we see that the aorta is very much dilated. Of course, aortitis could be a case, but then the aortitis, I think, would explain, although it is a possibility, aortitis could explain the difficulty in breathing, could explain the fever. The difficulty in breathing, I think that's what I'm struggling to think about. But yes, aortitis can cause fever. So I think that is maybe at least partly we need to know, yes, this patient has had an aortic dissection in the past, but maybe at least comparing the images in order to see if there is no change between when this was diagnosed and now. I think that is appropriate because at least in part aortitis can explain fever, and yes, to a certain extent, difficult in breathing. So I think those are the things. I think those are the top possibilities for me. Still a pneumonia with an atypical organism, but I think the coverage was just fine to say that this is that maybe we are dealing with the wrong organism. Pulmonary embolism, I think what I'll need to do is just to review the images with the radiologist in order to make sure that we are not missing an embolus. And then the possibility of aortitis causing the patient's presentation. And yes, there could be something else, but I think that's where I'm stuck now.
Okay. Yeah, so it's I went through the same struggle and the same journey, and I should say I love your approach of antibiotic failure. I will share it, of course, at the end to remind ourselves. I will tell you what happened. It was nice to take care of this patient because it was uh, diagnostic reasoning in real time. Me with my colleagues there, very nice. So based on the initial presentation, that is fevers, chest symptoms, as you're saying, truly light. Community acquired pneumonia has to be the number one diagnosis. But when we did the chest X-ray, it showed something more than that, a wide mediastinum. So as you did, we thought he must be having a mediastinal mass, which will be a risk factor for recurrent community acquired pneumonias. But when the chest X-ray could be explained by aortic dissection, then we were stuck. We said we have to go back and think again because the aortic dissection, it was chronic, it was nothing new, and even if it was new, it has to present with chest pain, not this presentation. So we also reconsidered the community acquired pneumonia. But again, after 3 days of antibiotic, when you treat community acquired pneumonia, the change you have to see it 24 hours, at maximum 72 hours. If no change, you have to think of something else. So it was not responding to treatment. But and I was thankful because I was with these junior colleagues, and when around the time of COVID, they told me they were medical students, but I was taking care of patients. The saturation of 70 to 80 in a patient was very calm. This guy was sleeping, and I can tell you, we ordered the the CT outside of the hospital, and there was no oxygen, which was a mistake, by the way. So I had to think this has to be a silent hypoxia, especially when we looked at the system and realized he came here some few days ago with a saturation of 100. So I thought this has to be a COVID pneumonia. And so we had nothing to lose. We didn't have the test at the hospital. We had to start this guy on dexamethasone. Luckily, that on the next day of single dose dexamethasone, oxygen requirement started to go down. Came from 8 there and then required like 4, 3, 2, and then we weaned this guy off oxygen after like 3 days. So I didn't have the test, but we deeply think this was a severe COVID-19 pneumonia, and so some things. This is what you are talking about. Very nice. When you giving antibiotic and the patient is not responding, think of these things. Maybe you are dealing with a long diagnosis. Maybe you think it's an infectious disease, but it's non-infectious. This is a malignancy, autoimmunity, or drug-related. Or maybe it's an infectious disease, but it's the wrong microorganism, like an atypical pneumonia. For example, here, we were treating community-acquired pneumonia. We added macrolide for atypical organisms, but there has to be a concept like a viral. COVID is a viral thing. Maybe it's a fungal or parasitic. But again, maybe the antibiotic is wrong. Maybe you are giving something, you are giving a skin and soft tissue disease, and you're giving antibiotic that cannot cover that disease, or patient is not taking the antibiotic, or you're giving it low dose, like you're giving maybe vancomycin and you haven't calculated the weight and it's underdose. Or you have to control for tissue. Maybe you are treating someone and they have an abscess. So yeah, abscess you have to control it. There is nothing else. You cannot just give antibiotic. It's just the natural history of the disease. Maybe the patient is responding, but the response is too aggressive, right? Things like in MRSA bacteremia or toxin mediated. Or it is too soon. You have to wait a little bit. and to see the change. Something on cyanide hypoxia, I had to go and read it because it was so nice. It was a cornerstone of this case, by the way. So it is an hypoxia without expected dyspnea. Someone presenting, for example, this guy, 70, and on the initial day it was just 30 Arara. And then later on, one doctor even said he went there and measured the count, the Arara when the patient was sleeping. It is around maybe 23. We were arguing around, maybe is it the Pazox that is abnormal, but the Pazox is normal. He did the patient's saturation all the days, which was not. So the pathophysiology is thought to be maybe because of blunted hypoxic drive, which is caused by direct viral effect on the brainstem. Like these virals go on the brainstem and they blunt the hypoxic drive. They go down, but you don't respond by having dyspnea. And again, another pathophysiology can be a preserved lung compliance because COVID mainly affect the vascular and it's an inflammatory disease. So maybe the lung compliance are still there. They'll be compromised later. So initially, you just have you are having desaturation, but the lung compliance is normal and you're breathing normally. Or it's just a VQ mismatch because of microthrombi in the vessels of the lungs. But whatever the case, just give oxygen. We did a mistake at this patient. At one point, we didn't give oxygen because it was fine, which was a mistake. And consider prophylactic anticoagulants due to microthrombi that can be present, and then treat the underlying COVID. So a little bit on COVID. It originated in Wuhan, China in the end of 2019, caused by SARS-CoV-2. The presentation can be asymptomatic to severe presentation. Only difference is where the symptoms localized. In mild is upper respiratory tract symptoms. In moderate is lower respiratory symptoms, but saturating normally. When they desaturate, that is severe. So this patient has severe disease. You diagnosis, you do the RT-PCR, performs better than the antigen tests. Treatment depends on the severity. Mild, just symptomatic treatment. If it's moderate, you look at the risk when if there is a risk to progress to severe COVID. And the risk generally means if there are any comorbidities and the age above 65. So if this patient, you give them remdesivir, very expensive. I've never used it. If there is no risk, you just treat symptomatically. But if severe COVID, then you give dexamethasone plus or minus remdesivir. I find remdesivir in this patient not to be so useful because it's so expensive, difficult to find, and dexamethasone works just fine. So I kept this patient dexamethasone and responded very well. Maybe David from you.
Thank you very much, Joseph. This was a good learning experience. A lot of I think there's a lot of thought-provoking issues. Helped refine my thinking on some things. So yeah, I think it was a lot of learning. And yes, sometimes we see, so maybe that I think what you did underlines one thing, that sometimes treatment can be used as diagnosis. So for example, you think about, okay, we are probably dealing with COVID, although we have not confirmed it. We have not confirmed it using the gold standard, but then with treatment and the patient response, so our confidence that most likely we're dealing with COVID is high. So that was a good learning experience. And then another the issue with I think the chest radiograph. Uh, the chest radiograph, that was very confusing for me at first, because thinking about a mediastinal mass, I see that our thinking was very much alike in multiple steps of you working through this case. So I thought about a mediastinal mass, but then when you presented the CT, and then I went back and looked at the image, then I think so that is what we call hindsight bias.
Yeah.
I think if you had told me initially that so this is a chest radiograph this patient has aortic dissection, I would definitely tell you, yes, I can clearly see that the aorta is very much dilated. So after the CT,
Sure.
I could see the margins very clearly that yes, this is not another mediastinal mass. If I trace the margins, I can see that this is the aorta which is dilated. So I think it was a lot of learning in that chest radiograph there. So thank you very much for the learning.
Yeah, sure. It happened to me also. The same thing. Every one of us were like maybe six doctors. Same thing. We also thought of that. Yeah, but I love the approach and the on different problems in here, and it is about diagnosis and management because I was going home, coming back, reading about the patient, some things not making sense, and then at the end, patient. The most important thing is to treat the patient, and they went back home happy. So, do we have anything else from the floor? Yeah, Antimony.
Good evening.
Good evening, Antimony.
Yeah, thank you, Joseph and David, for a very nice discussion. Um, it is it is a diagnostic challenge, but I was trying to think in the CT scan, could the radiologist report anything about the lung? I mean, the lung fields,
Yeah.
the lung parenchyma. Were there any comment on that?
Yeah, so he actually didn't because I remember I said something like the lung architecture is normal. So I wonder if he meant the lung parenchyma is normal or he just didn't report. It's unfortunate we couldn't contact him and realize. Yeah, that was a mistake from him, by the way.
I think I saw a hand from Okta. Okta, do you have anything?
Thank you very much, David and Joseph, for a nice presentation and reminding us of different things to learn. But again, I wanted to to give some few points as far as the pulmonary embolism is concerned. When you are presenting and trying to rule out pulmonary embolism, we came at a point where we had a general examination and vital signs. At least you should have told us about the vital signs in patient with the pulmonary embolism, especially when it's very early. Uh, we expect the heart rate to be a bit high, and this one is very normal. A patient has got very normal heart rate. Again, when we are reviewing the echo findings, at least we saw the left atrial dilatation. But because we have differential pulmonary embolism, I think it's very important to give other findings which we expect in a patient with a pulmonary embolism. As far as learning is concerned, especially here, we have residents who are following the presentation. As well, in chest X-ray, yes, we have seen dilated mediastinum, which is in keeping with aortic dissection. But we wanted to know some other features of pulmonary embolism in the chest X-ray, so that next time when we see chest X-ray of the patient who is saturating, and if we have a differential of pulmonary embolism, at least we could remember some of the features of X-ray the patient with some pulmonary embolism would have presented with, as what Dr. Antimon asked about the lung feeds to see if there is a watermark signs, Hampton Ham, some things like atelectasis and the raised hemodiaphragm, so that next time when we are reading the X-ray and having the differential pulmonary embolism, at least we would have thought about those findings in chest X-ray. Thank you.
Yeah, thank you very much, Okta. And yeah, I received those are very nice comments, by the way. The the review of the reminding ourselves of what can be seen on the chest X-ray. Of course, when you see those, yes, you have to think of that. But if you don't see them, you don't stop to consider the PE as a DDX. Yeah, but one thing that David, of course, we were arguing: should we order CT with contrast or CTPA? I read about it, and CT with contrast can pick PE if it involves the big vessels. So that's why it is not the gold standard. The gold standard is CTPA, but if it involves smaller vessels, it can miss it. Yeah.
Thank you, and of course, Okta, thank you for reminding about especially the vital signs. So it's something that actually, when I was rushing through the discussion, I forgot to mention about it, but it came to mind very clearly. The issue of the pulse rate. Of course, pulse rate is one of the things that even in the scoring criteria that we use when someone has tachycardia, it's one of the things that we use in scoring in order to see the likelihood of pulmonary embolism. So yes, that is a very well put comment. I wanted to mention it, but then I think I forgot on the way to discussing that. So thank you very much for reminding about that. And then the issue about chest X-ray, of course, as Joseph said. So first of all, those classic findings that are being reported about pulmonary embolism. So watermark sign, Hampton's hump. They are things which are they are not sensitive because you rarely see them in patients with pulmonary embolism. So uh, I'm not sure how many of us have worked through a patient with pulmonary embolism and were able to see them. So in a patient with PE, you might send a chest X-ray and it comes out completely normal. So they are not very sensitive. And again, so just like Joseph said, if you do not see them, they do not make you rule out pulmonary embolism. So, but thank you for reminding about those classic findings.
Yeah. Okay, I think we are above the top of the hour, and if there is no any other comment, I should thank everyone here. Thank you, David, for discussing this case, and I think we'll be here next Sunday again for another case.
Yeah, so next Sunday we'll be here. And again, as always, we keep making the call. So anyone who is interested in discussing a case, you're more than welcome. So just let any one of us, either Joseph or me, that you're interested with discussing a case, and you'll do that uh, whenever you are ready. And if you have a case to discuss, please bring it, even if the case is not complete or you do not have a final diagnosis based on investigations. We've discussed incomplete cases here, so please bring cases so we can learn from them. Otherwise, thank you very much. Have a good night and see you next weekend.
Good night.
Thank you.